Good afternoon, everybody. It's a great pleasure to welcome you all to the Royal Society of Medicine here in London on the occasion of the inaugural Journal of Pediatric Urology lecture and the award of the first David Frank medals. I think that we as a specialty owe a great deal to David Frank, who was the driving force behind the creation of the journal. He'd gained his experience in medical publishing with the British Journal of Urology and began to recognize the need for an independent pediatric urological journal. However, at that time in the 90s, opinions were very divided, and there was strong opposition from very senior people at that time. He was not deterred, and he approached the two major societies at that time to see if they wanted to accept ownership of such a journal, and they decided not to, and he decided to go it alone. The rest, as they say, is history, and he's been an immensely successful founding editor who is still involved with the journal today on a daily basis. In those early days, he was ably aided and abetted by Pierre Muricon and Pat Malone, who both gave tremendous contributions to the initiation and the early years of the journal. We must also happily acknowledge, I think, the great contribution by Elsevier, and we've traveled the road together, and the partnership has resulted in great success and the situation which has allowed us to sponsor the journal lecture and medal that we're going to hear today. Indeed, on this inaugural occasion, we're going to have two lectures, both looking at, from different perspectives, at the future of pediatric urology. And they will be followed by a panel discussion, which will be chaired by the Editor-in-Chief, Tony Caldeman. Our first speaker is Professor Nicolas Kalfa from Montpellier in France, one of the oldest and most famous universities in the world. Trained in Montpellier, he spent fellowships in pediatric urology in Toronto and San Francisco, and is now chief back in his hometown of Montpellier. He has a very distinguished career. He heads the Rare Disease National Reference Center for DSD and has been president of the French Society for Pediatric Urology, as well as holding several positions within the structure of the European Society. He's a modern young man who is as fluent in the language of molecular physiology as the high-tech robotic surgery, and he's well placed to look into the future of pediatric urology imaginatively. One small thing, in his CV, it is noted that he holds a pilot's license. Indeed, both our lecturers today hold pilot's licenses, which he modestly qualifies as single engine only. But as with materials and methods, the devil is in the detail. And given his record in pediatric urology, it may well be that when an Airbus 340 loses 3 of its engines, that's when they call on Nicolas to take over. So we will ask you to take over at this moment with our engines failing and lead us into the future of pediatric urology. Professor Nicolas Kalfa.
Dear sir, ladies and gentlemen, dear colleagues, thank you very much for this kind invitation and to give the inaugural JPU lecture to some of the most eminent members of our discipline in this prestigious place. So it's a great honor for me to speak to you today about the future and the changing face of pediatric urology. I'm pleased to be here as part of a long tradition. You may recall that as early as the Napoleonic Wars, doctors from our two countries were given safe conduct to join the Academy of Medicine of the other country. Neither Brexit nor COVID has prevented us from meeting today. The subject you asked me to cover is difficult, In 1953, a book titled Modern Trends in Urology was published by renowned specialists. Some parts were highly relevant, such as the condemnation of the indiscriminate use of antibiotics or the progress in endourology. However, also many of the trends turned out to be accurate predictions, others were not. Indeed, such practices as translumbar orthography have been totally abandoned today. Predicting the future of surgical specialty is thus a tough balancing act for three reasons: uncertainty about future technologies and the role they will play, unforeseeable revolutions, and non-medical and non-scientific events that may influence the future of pediatric urology. Our world does not look so uncertain since the two world wars, and disruptive elements are to be expected. What that means is that any predictions that are made today that may, by chance, end up in a few years as prophetic, or they may completely miss the mark. Let us pose one starting hypothesis. A new burden of disease will not occur in pediatric urology. Non-contagious diseases such as diabetes or obesity are hypothesized to have minimal impact in pediatrics, contrary to the case in adult surgery. Pandemics and antibiotic resistance are expected to rise in the future, but again, with a moderate impact in our discipline. The frequency of most pathologies remains stable, except for a moderate increase in cancers and congenital anomalies due to the possible effects of pollution. Keeping this in mind, we can probably expect that the future of pediatric urology will depend on technological advances in the OR and progress in other disciplines. If the exponential progress continues, we will undoubtedly see the creation of more multidisciplinary teams, and pediatric urology will not be confined to the OR. It will also have an increasingly preeminent role in public health medicine, since the health of our young patients today is an indicator of the health of the general population of tomorrow. Two key issues will need to be addressed: a new equation in the training of pediatric urologists, and a new challenge in ensuring equal access to information. Moreover, tomorrow's pediatric urology will also be shaped by a changing society. It would be naive to believe that the future of our discipline depends only on medical and technological events. Technological advances in and around the OR are the first drivers of the changing face of pediatric urology. And let me say here that I'm not an expert in all the domains we are about to cover. I have only approached them through the eyes of the surgeon of today, who will now try to predict how they may interconnect with his discipline. First, surgery of the future rhymes with robotic surgery, and minimally invasive surgery has been a pervasive tendency for decades. Exploratory laparotomy is now an object of curiosity for our students, as it has given way to laparoscopy, endourology, increasing miniaturization, and laparoendoscopic single-site surgery. The expectations in pediatric urology are high that morbidity, pain, hospitalization stays, and adhesion formation will all be reduced, with costs also eventually dropping once the techniques are sufficiently democratized. In fact, the search for this holy grail will not meet with success in the very next few years. We recently reviewed the findings of evidence-based medicine with regard to minimally invasive surgery in pediatric urology, and the results were quite disappointing, with a low level of evidence. In fact, the development of surgical techniques comprises three distinct phases. It can't be done, it can be done, and it should be done. And today we are still in the second phase. It should be pointed out that robotic surgery might be the surgery of the future rather because it allows for the use of other technologies. First, augmented reality is a live visualization of radiologic images projected on the surgical field. This technique remains quite challenging in urology because visceral structures are soft, and it thus requires a high capacity for calculating deformation. The association of robotic surgery with artificial intelligence opens up new perspectives. On-screen checklists automatically adapted to the operating step, or the detection of risky situations through the analysis of structure deformations. We will discuss this in greater detail further on. And robotic surgery will also likely provide a more faithful and reproducible training than open surgery. Last, remote assistance by specialist surgeons will be facilitated, thereby improving outcomes. The next step will be automated procedures. Being a private pilot myself, I find parallel between surgery and aeronautics. A plane landing without human assistance was simply not imaginable 50 years ago. Nowadays, computers help land an Airbus more smoothly than a human in conditions of limited visibility. In future pediatric urology, automated suture sequences might be possible for a UPG, for instance. A robot could also automatically biopsy a tumor after three-dimensional acquisition of the surrounding vascular structures. And these automated procedures would still be triggered by a human decision, just as in jets, where the autopilot is manually engaged under certain conditions. But fully automated procedures from start to finish are not, in my opinion, just a dream. Airbus again recently completed the first fully autonomous flight, and something similar will perhaps be the case in the OR in several decades. The 3D printing has become democratized in recent years. And to prepare for this presentation, I had the opportunity to talk with Professor Captier, a pediatric plastic surgeon and anatomist, who has experience in the modeling field and works in collaboration with a computer science laboratory. And 3D printing should be of great interest for us for three reasons. Preoperative planning in almost real situations. This already exists in facial reconstruction, chest reconstruction, heart surgery for congenital defects. And for example, managing a bladder extrophy would theoretically benefit from the creation of a model of the patient acquired in 3 dimensions by imaging. The intervention could be planned out before D-Day, and this would enable the physical assessment by touch of the bladder capacity, the reducibility of the diastasis, and the efficacy of the different osteotomies in order to choose the best one. Prior simulation of the procedure would improve the final results. And Captain Sully had certainly simulated the takeoff engine failure many times before he saved all the passengers on US Airways flight by making a water landing in the Hudson River. In addition, 3D printing will enable the design of patient-specific material. Some implants are designed to the millimeter for mandibular malformation. Certainly, the application in pediatric urology will be more complex. The soft structures move, the anatomical relationships are numerous, and the creation of a 3D model that takes into account the distinct plasticity of each organ is a daunting technological experience and challenge. 3D printing will also enable the design of custom devices that respect the anatomical imperatives of pediatric urology, such as this flexible fetoscope designed for the prenatal treatment of the posterior urethral valve and presented at the last JPU meeting by the Paris team. Last, telemedicine offers new possibility in urology. Alongside the classical teleconsultation that we carried out during the pandemic, 2 areas are expected to develop in pediatric urology: Teleexpertise, telementoring, and even telesurgery. The feasibility was demonstrated 20 years ago in adult GI surgery. At that time, the connection speed was a limiting factor. But today, even video game competitions benefit from high-speed streaming with low latency. Technical challenges remain to be overcome, particularly achieving a perfectly stable connection and lowering the cost of dedicated lines. The other aspect of telemedicine that pediatric urology might benefit from is remote and continuous follow-up. Connected watches already monitor the occurrence of hypoglycemia and arrhythmia in diabetic and cardiac patients. Wearable devices could be of a great help in functional urology, for instance. The monitoring of neurological bladder or voiding dysfunction will no longer be followed in periodic consultations, but will instead be accomplished by mobile devices that monitor the emptying of the bladder, thus providing real-time, continuous, and real-life feedback to the patient and the urologist. Limiting ourselves to purely surgical technological progress would be a fatal error for our discipline. It's crucial that we see beyond surgery itself. Genetics, artificial intelligence, big data, tissue engineering and cellular therapy and liquid biopsies will no doubt be an integral part of the therapeutic arsenal of the pediatric urologist. And the advances in genetics have been huge. Next generation sequencing led to a dramatic decrease in the cost of sequencing. 15 years ago, only 10 human genome sequences were performed in a year worldwide, and today, thousands can be done. This is thanks to the massively parallel sequencing of several patients and several genes at the same time in the same tube. This is exactly as if instead of one person alone reading a whole library of books, hundreds of readers randomly read all the books in the library at the same time, and then a computer then reconstructs all the texts. Genetics is relevant for our patients. It will help determine the pathophysiology of numerous pediatric urological conditions, and this is the first step toward treatment and prevention. Genetics will improve our diagnostic performance. For example, in DSD, genetics can predict fertility at one point, help optimize pubertal development, and detect hidden syndromes even before developmental delays occur, as we reported in a recent publication. The next step may be preventive surgery. Indeed, many diseases have an inherited genetic predisposition, and this is well known for non-pediatric conditions such as BRCA1 and 2, which determine breast and ovarian cancer. In pediatric urology, the future will reveal how far we should go in implementing this type of data. For example, would young people with a genetic risk of adult hypertension benefit from proactive surgical management of acute? Do WT1 mutations in asymptomatic children justify specific kidney monitoring? Or do cysteine metabolism variants justify preventive treatment with troponin or penicillamine? Using such genetic data carries two risks and poses one major challenge: the risk of over-treating asymptomatic patients and stigmatizing some individuals with consequences for employment or insurance coverage, and the massive challenge of learning how to efficiently integrate this complex data in our decision process. For the moment, however, genetics will serve as a tool for tailored follow-up thanks to individual prognostic factors with individual risk assessment. All this implies that our work will shift from surgery for ill children to implementing measures to prevent the onset of urological condition in healthy children. Some reports even predict a reduction in emergency surgery. Genetics also include pharmacogenomics to identify targets at the individual level by predicting the response to a particular treatment rather than applying standard protocols based on population resources. An excellent example is cancer treatment. Our patients with nephroblastomas or gonadal tumors may well benefit from targeted personalized therapies. The pharmacogenomic of bladder dysfunction may also make it possible to predict more precisely the response to a drug treatment. And standard protocols will belong to the past, and we will move toward personalized treatment. And finally, epigenetics is a highly relevant domain for pediatric urology. Epigenetics is a study of the modification in DNA methylation which influences gene expression without altering the genetic sequence. And many congenital disorders are due to disruption in imprinted genes, which are particularly sensitive to environmental factors. It is currently difficult to use epigenetic data because the studies require direct sampling from tissue that are sometimes useful for surgery, as in genital surgery, which raises technical and ethical issues. Artificial intelligence is expected to hit all domains of surgery very soon, and its interest in urology was reviewed at the AUA Congress 3 weeks ago by an expert panel. AI is based on machine learning and goes from data to output prediction by detecting specific patterns in the data. It uses machine learning, guided by human algorithms, or autonomous deep learning. Most applications are now used for diagnosis and outcome prediction. In adult urology, for instance, evaluation of the risk score from histopathology in prostate cancer is even more reliable using AI than human. The Toronto Pediatric team recently trained a convolutional neural network in the task of predicting differential kidney function based on renal US images. And the computer was able to determine areas of interest and predict the results of nuclear scans even without implementing clinical variables. Further applications of AI are now at the doors of the operating room. AI systems have been developed to recognize bladder cancer after bladder augmentation in real time during endoscopy, in order to guide the surgeon to the right area for biopsy, even in the absence of an obvious visible lesion. AI is even capable of predicting the nature of a stone in real time during endoscopy, far better than trained urology residents. Last, AI provides a new way to evaluate the surgical skill by studying the surgeon's movement and generating automated performance metrics. Based on each step of the procedure and even each of the surgeon's movement from needle positioning to the quality of knotting, AI is more capable of predicting the length of the hospital stay and even the time to reach continence after robotic prostatectomy than examination of patients' data. Now, none of this is totally new for us, because we have been trained to be evaluated by highly complex systems since our earliest childhood. Artificial intelligence goes hand in hand with big data, and big data analytics is probably the next big revolution in pediatric urology, with far-reaching technological and ethical implications. It means gathering huge amounts of anonymous data at the population level and using complex algorithms to detect similar patterns of development in order to identify the most relevant variables that determine the future of each individual. Let's take an example, the example of a reflux. Today, we mainly use grade, gender, kidney function, and the occurrence of infection to predict prognosis. But other factors that we currently do not know how to integrate also come into play. The family history, the other non-urological disease, susceptibility polymorphisms in the genes of kidney development, individual response to oxidative stress, microbiota, environmental exposure to nephrotoxic substances, nutrition, and so on. So big data analytics will help to solve this puzzle and will guide us to determine which patient will best benefit from the surgery. As summarized by a recent report of the Royal College of Surgeons, the effective use of big data presupposes that several issues have been dealt with, especially the ethical issues of data collecting, the need for international regulations before the privatization of all this data, a process that is now well underway, and the willingness of practitioners and patients to use the database and AI, and this implies that they trust the system. The last issue concerns the capacity to aggregate data coming from very different fields. For instance, we are now working on how to assess the combined effect on clinical data, genetic data, and exposure to environmental pollution to determine the risk of urogenital malformation. And this is a major mathematical challenge. Cellular and tissular technology are the next big hope for the future of pediatric urology at 3 levels. At the cellular levels, stem cells are the subject of intense research, particularly in diabetology and hematological disease. In urology, urothelium was obtained several years ago from stem cells, and stem cells have also been injected in the bladder neck of infants with bladder extrophy. Animal models of stem cells transplantation in seminiferous tubule led to spermatogonia and may offer a new hope for infertility treatment. This research has profoundly influenced the way we are managing the gonads of our patients today, so as to keep all possibilities open in the future. 2 recent Nobel Prize winners have provided new direction for the use of these stem cells. First, they showed the ease of extracting them from somatic cells, and these are iPS. This is important because it avoids both the ethical problem of using human embryos and the problem of immune rejection. And second, the CRISPR-Cas9 genetic modification technology, which works like scissors at the DNA level, facilitates the genetic editing of the cells and is a hope for the treatment of genetic conditions. At the tissue level, the repair of congenital anomalies requires the replacement of the missing tissue. And our technique often uses unsuitable tissue such as the skin or oral mucosa in genital surgery or intestinal tissue in bladder surgery. And tissue engineering could provide a solution. The engineering of urethral tissue is a goal of research by numerous teams and even for corpus cavernosum. Nevertheless, we must be careful and we must keep our hope in perspectives. Bladder tissue engineering, which has been in development for several years, has not yet reached the stage of large-scale clinical use. At the organ level, the pediatric kidney transplantation is plagued by several problems: organ shortage, long waiting list, risk of rejection, high financial cost, and the morbidity of immunosuppression. and 3 technologies will probably change the fate of pediatric transplantation in the next decade. In the short term, immune reprogramming may be an alternative to immunosuppression. This is an immunological approach to induce lifelong acceptance of tissue or organ graft by modulating targeted antigen presentation. Then, in the midterm, 3D bioprinting could produce bioengineered organs by layering living cells on top of each other to eventually create an artificial living tissue. And this is expected to enter surgical practice within 2 decades. The difficulties will be the real and effective function of the organ and its integration into the systemic vascularization. And last, in the long term, organoids offer an incredible hope. Organoids are small functional organs that are produced in vitro from undifferentiated cells. And kidney organoids have been successfully produced with a variety of cell types similar to human nephrons and producing urine. Approaches to generate more complex kidney structures with collecting ducts, ureter, and vascular flows, which are required to generate transplantable kidneys, are in progress. The last advance in biology that may change the face of our discipline is liquid biopsy for the study of the circulating cells, as opposed to the focus of organ biopsy. And liquid biopsy is about to enter clinical practice. But pediatric urology lags behind this area. And to prepare for this presentation, I had the opportunity to talk at length with one of its inventors, Dr. Alex Panabiar. In the course of our discussion, we imagined how pediatric urology could benefit from liquid biopsy. In adult medicine, it was especially designed for cancers with poor prognosis and high metastatic potential, such as breast and prostate cancer. And pediatric kidney tumors would theoretically benefit from this technique as well. The detection of circulating cells would allow postoperative follow-up for the early detection of recurrence. The genetic study of the circulating cells and the detection of circulating lysosomes could establish prognostic factors more reliable than the current techniques. The use of other fluids, such as urine, is also possible. The sample would be closer to the tumor and perhaps more sensitive. Further into the future, skin sensors to detect circulating tumors could offer a new generation of postoperative monitoring remotely and continuously. And liquid biopsy could also be of interest in pediatric urology for non-cancerous conditions. Trophoblastic cells are indeed detectable in the mother's blood and offer unique access to the fetus in the event of a urogenital anomaly. Alongside the technical progress and growing need to adopt a multidisciplinary outlook, pediatric urology, in my opinion, is set to become part of public health medicine. First, pediatric urology attends to factors that are precursors to the health of the adult individual. For instance, acute kidney development and hypertension. And second, it provides a unique information on the health status of the general population. The most striking example concerns genital malformations. The countries with the most hypospadias cases also have the most testicular cancers and the most fertility problems. There is a temporal and spatial correlation between pediatric urological abnormalities and the overall rate and the overall health of the population, and particularly fertility and cancer. The pathologies we deal with are the sentinels of the future public health. It's no coincidence that some genes are both urinary developmental genes and oncogenes. Exposure to endocrine disrupting chemicals can also explain both pediatric urological conditions and many diseases in adulthood, including endocrine, respiratory, and autoimmune conditions. Another striking example comes from the Glasgow team, which recently showed that hypospadias signals a higher risk of cardiometabolic event later in life. Another example comes from one of our fellows who identified variations in the rate of prematurity while working on the epidemiology of urinary tract defects during the COVID lockdown. And this indicates that pediatric urology has a role in the wider field of population health. The technical progress we are seeing today is a great opportunity for our field, but it raises the problem of an equitable access to this technique, as it will be explained in detail by Dr. De Vries. But also important is the equity of access to information. And information is already a difficult part of our job. It should be accessible to the parents and to the child according depending on his or her age. The complexity of the previously described advances and the speed with which they are being adopted by our discipline will make this task even more difficult. Erroneous and partial data will be increasingly available in the media, often not sufficiently fact-checked, increasing the disparities in comprehension. It will be hard for future pediatric urologists to ensure equal access to accurate information, even though this is a basis for trust and treatment compliance. And these ambitious goals for the pediatric urology of the future require adaptation in our teams and in the training of pediatric urologists. In the short term, addressing the high specialization of surgeon is the first step. And some decades ago, it was not uncommon in some countries for a pediatric surgeon to be a digestive, plastic surgeon, and urologist at the same time. Being able to perform all the procedures was once a testament to the surgeon's ability to adapt to different circumstances. And this situation has reversed in recent years. Specialization in pediatric urology is now considered a guarantee of the surgeon's experience. There is no longer any doubt as to whether the volume of a given procedure improves its results. This factor is sometimes even more important than the surgical technique itself. This high specialization of pediatric urology goes hand in hand with the creation of national and international reference networks. This is a clear tendency, although the degree of progress differs from one country to another, from one continent to another. And several networks for pediatric urological conditions already do exist in France to provide recommendation to help the referring of patients to competent centers across the world territory. The second point is the extensive use of simulation. And to prepare for this presentation, I was fortunate to be able to discuss with one of the French national leaders of surgical simulation, Dr. Herrero. Training in pediatric urology will include 3 steps. One, the basic skill training using mechanical simulation and software simulations, which are quite used now. The second is a skill for rare but important procedures, such as an emergency salvage nephrectomy that may use a new generation of revitalized cadaver with artificial circulation. And step 3, the complex scenario to approach the development of teamwork and team communication. But learning in pediatric urology cannot be done through simulation only, and it will be important in the future to recognize the still invisible teaching in the operative room and provide metrics for it. Besides simulation, we also need to anticipate the integration of all the advances we have described so that our patients can benefit fully from future opportunities. And for this to occur, we must change the way pediatric urologists think, work, and are trained. The future of pediatric urology is not only in the operating room. It's not just a matter of performing surgery. We need to teach future pediatric urologists how to interact effectively with artificial intelligence specialists, data managers, bioengineers, regenerative medicine, and so on. This means that we need to start training multifaceted pediatric urologists. The curriculum of our students should be open on the research and innovations in other disciplines, despite the years of dedicated study already required to become a top-notch surgeon. The pediatric urology team of the future will have to recruit from other non-medical fields, and we can no longer assume that we know everything. The consequence is that the position of the future of the pediatric urologist will be blurred. These specialists will no longer be just the ones who incise a child's body. Instead, they will take the role of coordinators of multidisciplinary teams, with all members working together to treat and prevent pediatric urology conditions. Our team, for instance, has been surrounded and greatly enriched by specialists from other disciplines: geneticists, computer scientists, bioinformaticians, molecular biologists, data analysts, epidemiologists, environmental scientists, and pure mathematicians. Who will study the role of environment in hypospadias if not us? Who will develop bioengineered bladder tissue if not us? Thus, pediatric urologists will no longer spend most of their time in the OR. Instead, their focus will increasingly be on prevention and monitoring. This fact has already emerged as a clear trend in the past several years, and the surgical-non-surgical activity ratio will continue to decline. If pediatric surgeons can only imagine themselves performing surgical procedures, they are doomed to disappear. The volume of activity will decrease, and the cost of the surgical training will no longer be justifiable, and the technical procedures will be entrusted to non-medical technicians. For instance, radiologists used to perform all X-ray a few decades ago. Today, technicians do that, while radiologists interpret images and develop radiomics. In the same way, but at another level, Thomas Pesquet, the French astronaut, refused to be limited by his training as an engineer, but went on to have a place today on the International Space Station. Another key element in the education of the future urologist is the human factor. The human factor as an error factor. Pilots learn to deal with human mistakes, as we need to learn to manage the human factor in OR. As a communication factor in complex teams, we have to learn several languages beyond medicalese in order to coordinate multidisciplinary teams. And finally, as a factor of our very humanity, our reliance on and even awe of technology must not cause us to lose our humanity. We will remain doctors with a human touch, especially since we are dealing with children. Last, but not the least, pediatric urology will evolve with the world society. At the world level, demography is an important factor. The low birth rate in Western countries and the high proportion of children in Asia and Africa strongly suggest that new countries will emerge as innovation leaders in pediatric urology. The increasing diversity of countries publishing in international journals and the size of some series recently published in pediatric urology illustrate this coming change. We are also expected to evolve with our society, and society gives a growing role to the party autonomy of the individual. To prepare for this presentation, I was able to talk with Professor Viala, a specialist in medical and health law and the creator of the European Center for Law and Health Studies and Research. And during our discussion, I became aware of the extent to which future ethical issues in our discipline are likely to be linked more to society than to technologies. The principle of party autonomy is hitting pediatric urology now and will change the face of our discipline. This principle establishes the individual will as a creative source of law and obligation. And for example, social infertility, and not only pathological infertility, can claim the use of assisted reproductive techniques. In pediatric urology, the patient is often not yet autonomous, but this movement of party autonomy is also recognized for children. And calls have therefore been made to establish a pre-majority age to ensure that minors have a voice in the health matters that concern them. In Quebec, this has been set at 14-year-old. In France, it's more ambiguous because it depends on age and maturity, with a case-by-case analysis and fuzzy limits. The principle of party autonomy raises questions about the legal value of the family choice, especially in some European countries. The pediatric urologist of the future will therefore face an empty period of time, where the child is too young to express his or her autonomy of choice, and the value of the parent's authority is called into question. This situation may lead to two pitfalls: either compulsory therapeutic abstention or 100% decision-making by the medical profession without the parents. Neither is suitable. The first solution because it's too rigid for medicine, which is not an exact science. The second is definitely not a good solution because, as a recent English report rightly stated, a doctor cannot form an objective medical view of quality of life or body appearance and is therefore not in a position to make the right decision for these matters. A problem thus emerges around non-vital and preventive surgeries, and future pediatric urologists may find themselves facing an unprecedented ethical crisis. In conclusion, the future of pediatric urology will unfold not only in the operating theater. Technology is developing at exponential rate. The integration of robotics, genetics, biology, data processing, and AI will make the pediatric urology team of the future multidisciplinary, and the pediatric urologist multifaceted, even if we should expect some clouds and turbulences. As the saying goes, otherwise we will miss the boat or the rocket. Our work will increasingly consist of preventing urological disease, and the main challenge of pediatric urology will be to integrate all these changes and to adapt to a quickly moving society. Thank you very much.